First of all, we want to know what disorder is causing the tinnitus. This is the most important step. Never, ever try to do a treatment without being specific about the disorder that is causing the perception. When you have done this, things become so much easier. And this is my message for you. First, try to find the causing disorders behind your tinnitus perception. This is the game changer, because then you can focus on your therapy and you can be assured that most of those disorders are treatable and curable.
Dr. Michael Golenhofen is a leading ENT specialist and tinnitus expert in Germany, with years of experience treating tinnitus with complex causes and symptoms. Definitely hands down how you've positively impacted me and our team at Treble Health is this framework around the root causes of tinnitus. We know that there are different root causes and we try to identify them, but a lot of professionals fall into the trap to say, oh, your tinnitus is caused by your hearing loss. So could you provide a quick review of the three most common subtypes of tinnitus?
Yeah, you just mentioned the hearing loss subtype, which is, of course, in some ways self-evident. Tinnitus is an auditory symptom, and hearing loss, through the mechanism of deafferentiation, of simply a lack of input from the ear to the brain, causes a tinnitus, very often, especially when it's an acute type of hearing loss. And this is also involved in other subtypes, but as a matter of fact, the inner ear-related subtype, where the hearing loss causes the tinnitus perception by a reaction from the auditory brain, is a very common subtype in an ENT physician practice, of course, self-evidently.
It certainly is. It certainly is. And
Definitely.
the different subtypes of central versus somatic, what are some quick tips for patients to ask themselves, does that apply to me?
Well, the symptoms that show when a tinnitus comes from the auditory brain is a bilateral tinnitus perception that's often perceived in the center of the head, not primarily in the ear. So this points toward a central, a brain-related subtype, whereas the somatic subtype usually starts very quickly. It's a moment where it starts, and it starts in one ear, usually without a hearing loss. It's not easy to do an auditory test and an audiogram in these patients because the tinnitus sometimes covers in some way the test tone, but the somatic subtype does not have a hearing loss accompanying the tinnitus perception. So that are the main important symptoms that everyone can know of and can use as a helper to differentiate those important subtypes. The hearing loss points toward the cause in the hearing function, whereas the monolaterality shows very often in the somatic subtype, whereas the central subtype usually comes slowly and is more this bilateral tinnitus perception. And this helps very much already to differentiate the disorder.
So the big message here is that there are different root causes of tinnitus, and an effective treatment is only as good as identifying the root cause at play and personalizing or targeting the treatment to get as close to that root cause as possible. Makes total sense. This is how medicine should work. And everyone should know that there are treatments available for the various subtypes, the various root causes, and that's, your job, my job, to help patients along the way. Let's talk about issues related to the jaw or even the teeth, because someone listening may think, I have no idea why problems with my mouth would affect my ear. How can I hear something that's going wrong in my jaw? This may be related to the fifth cranial nerve, the trigeminal nerve. Could you please expand on this? How exactly does this work? Is the nerve going close to the ear, or is this nerve meeting in the part of the brain where the hearing perception is? Could you please explain?
Yeah, that's exactly the fact that the trigeminal nerve is going to the brainstem. It is meeting directly with the hearing nerve where the hearing information comes in. And we need to know that everything that has to do with our teeth and the chewing function and the TMJ function was of utmost importance for our survival in the evolution of mankind. So when we lost teeth, it could be our death sentence. It is highly represented from the nervous system, everything that happens with the masticator system, with the teeth, with the TMJ function. We see that when we see the somatosensory representation in the brain. You might have seen this homunculus, which shows the percentage of representation. And this little drawing of the human body has huge lips and teeth and only very small arms, for example. That means that the nerve representation of anything that happens in the head, especially the dental situation and the masticator system, TMJ, is hugely represented. And the trigeminal input coming from the teeth and everything that has to do with our chewing function is highly important for anything that happens in the brainstem where the auditory information is integrated into the somatosensory information. So it is way more important what happens to my teeth in regard to a tinnitus situation than, for example, what happens to my knee. So as a matter of fact, anything that happens with the teeth is of primary importance.
One of the key contributions from Dr. Golenhofen has been the root cause assessment. And at Treble Health, we created something called Root Cause ID. Any patient who works with us in our Tinnitus 180 program goes through a thorough evaluation called Root Cause ID, where we evaluate the different subtypes or root causes at play for this individual's tinnitus. It's been a game changer and allows us to provide root cause specific treatment for that patient, leading to better outcomes. And what we see is that our overall success rate at Treble Health is 85%. That means 85% of patients have a clinically significant reduction in their tinnitus. That means sleep is improved, they're not hearing the sound as much. Oftentimes the volume of the sound decreases. They're able to work, be in quieter places, read on their couch. All these things that tinnitus had taken away, they're starting to get back in their life. And that only continues over time. If you're interested in learning more about Treble Health, I'll include a link right here. You can book a call with a specialist from our team and ask questions, get an introduction to how this could work for you, and be presented with the right tinnitus solution for your specific case. Right there, you can book the free call, and we're looking forward to helping you out. Now let's get back to the podcast with Dr. Golenhofen. So Dr. Golenhofen, I think an analogy for this is, let's imagine that we have these two wires that have unprotected electricity going through them, so they may be affected by other wires in the area. Well, if both of those wires are relatively close, one is related to the hearing nerve and the other is related to the trigeminal nerve, or the jaw, the teeth, the dental area. If that dental area is hyper aroused, or there's a lot more energy going through it, some of that information could jump over to the electrical wire of the hearing nerve. And the brain higher up can't really tell where it's coming from. It just kind of hears sound, or it processes more through the hearing nerve as tinnitus. So perhaps the metaphor is we need to reduce the electricity or the intensity of that trigeminal nerve so that the hearing nerve isn't picking up the signal from the crossover. Is that helpful?
Yeah, to some point, it's a little bit different and not so very difficult to understand, actually. Both the hearing nerve and the trigeminal nerve meet in a family of cells that integrate. It's like a computing activity, so to say. And when the information from the trigeminal nerve is very chaotic, is very sick, so to say, then the integrating function of these cells is over-challenged. They just do not function anymore. As our computer can be over-challenged by too many programs, computing too much information. And when these integrating cells do not function anymore, they send chaotic signals to the brain which is basically the tinnitus sound. So this might be the idea behind it, and it's a very simple process. That's why the somatic tinnitus is so simple. It starts very quickly. You do something right, it goes down, and so on. So it follows very quickly what we do in a therapy, whereas other subtypes react much slower because they're related to the brain and the auditory activity in the auditory brain areas.
That's
But the
correct.
somatic subtype is really reacting quickly.
That's correct. Well, these visual analogies are certainly helpful for us here and for those listening. Let's jump into a few specific case studies. Can you describe a patient with neck or jaw-related symptoms, and then what they use to get relief? And then we'll talk about someone who has tinnitus caused by hearing loss, and finally, someone who has tinnitus caused by a very loud noise. So first, the patient who has a neck or a jaw issue. Do you have a recent case study that comes to mind?
Yeah, I remember a patient that was very, very tight in his muscle function all over his body, especially in his neck. And he suffered from severe neck pain, and he developed a monolateral tinnitus perception. And we decided to do an MRI of his neck and found that there are some protrusions in the neck area that actually needed surgery. And we decided to do this kind of surgery combined with a bimodal stimulation treatment. And the tinnitus ceased after a couple of weeks after surgery. So what I want to say with this is good to combine different treatment approaches and not to leave away anything that might seem important. And in this case, it obviously was the combination of the surgery on one side and the bimodal treatment on the other side that helped him very quickly. And at the same time, I remember one patient that had to pull some teeth in one quadrant and got a compression in the TMJ. And all we did was to do a splint that would support the lower jaw at nighttime so that he couldn't compress his TMJ during nighttime and during sleep, while we physiologically press very hard with our lower jaw towards our upper jaw in order to put our teeth in place. And the night guard helped him very quickly. It was weeks the tinnitus ceased. So the moment you find the right treatment, the somatic subtype usually reacts rather quickly.
I love that. Let's now talk about a patient with hearing loss related tinnitus and the role of hearing aids and sound therapy in managing their condition. What do you see for patients in your clinic regarding that?
It's, of course, an everyday thing in my practice. That's self-evident. And if a tinnitus sound, for example, after a sudden hearing loss that is not recovering completely and leaves a asymmetric hearing loss on one side, causes a tinnitus perception, it is always important and the first measure to take to restore the hearing function as far as possible. With hearing aids, we can often do this. When it's maybe a hearing loss of 30 decibels that we can compensate completely, that usually lets the tinnitus cease as long as the hearing aid is worn completely, at least to a point where everyone would say, I have no trouble with it anyways. And we need to know that the tinnitus subtype that is caused from a hearing loss is rather benign, even when the hearing loss is there, even when there is some form of hearing loss. It doesn't bother so much as it would do when it's a somatic subtype, for example. The somatic subtype usually bothers very much. The inner ear related subtype doesn't do that so much. Many patients tell us even they're deaf since an ear infection in childhood, but they hear a certain sound, but it doesn't bother them. So in the hearing loss subtype, we need to know restoring the hearing function is the first measure we want to take. And on the other side, even when some tinnitus stays after treatment, the brain has the capacity to use its plasticity to basically let fade out the tinnitus perception over months and years. So it's always important to counsel and to recommend let's wait and see. We restore your hearing function as far as possible. The rest will be done by your brain if the circumstances are good. And it will never really cause a problem for you in life to have a tinnitus from a hearing loss. Usually it doesn't.
It's consistent with the patients we see at Treble Health that when there's primarily a hearing loss related to tinnitus component, the treatment is fairly straightforward and very successful. We recently ran data on all the patients that we see, and 85% of all patients of various subtypes had a significant improvement in their tinnitus. So I wanted to share that message that tinnitus is treatable for a vast majority of patients who get the right care. And that's what you and I are here to do, is make this process easier and more evidence-based for people. Let's definitely touch on the third subtype here, the central subtype. I also wanted to add to anyone listening, these are not mutually exclusive. You can have multiple at the same time. For example, a very common combination that we see is someone who has a pre-existing high-pitch hearing loss, but then over the last few months, they developed this loud, intrusive tinnitus. Most often, that's a hearing loss subtype related to the central or stress-induced subtype. So could you explain a case study of the central subtype who came to your clinic, Dr. Golenhofen?
Yes. This is a very important point that you just mentioned, because the inner ear hearing loss and the central subtype, the subtype that is basically happening in the auditory brain, is very often related, especially in elderly people. Of course, because they usually have a hearing loss that is pre-existing the tinnitus perception. But the typical subtype of the brain-related one is one that occurs to very young people, like 18, 20 years old. They come and say, I hear a bilateral tinnitus perception, and they have a perfect hearing. This is important to know because it tells us there is a purely brain-related subtype in some patients, And then it is important to tell the story about the filter function that usually covers a tinnitus perception that is intrinsic. We all have this tinnitus perception, but we filter it away. But when there is a certain anxiety in the system so that we want to scan for danger, then we reduce the filter function, and what do we hear? A bilateral tinnitus sound. So this is the typical brain-related subtype that is also found in very young people with a perfect hearing. And then we have the majority of people that have basically a certain hearing loss combined with the brain-related subtype. Either they have a hearing loss since years, but they have a tinnitus perception since a couple of weeks. So it's important to counsel in a way to say, well, you have a hearing loss, yes, and we might use a hearing aid because we want to help you restore cognitive functions by making you the hearing a little easier. And we want to take the advantage of using hearing aids in reducing your tinnitus perception. Of course, we want to take this advantage. But on the other hand side, we need to know that the actual cause of your tinnitus is the one that is related to the brain-related tinnitus subtype. So we're talking about anything that happens in your mind, in your soul, in regards to anxiety, depression, and so on, that makes you wish to scan your environment for any danger that could hurt you. So it is very important to do a distinct counseling with these patients and explain the subtypes. That creates so much understanding and also a very relaxed state to continue on a therapy when I know what is actually happening with me. And in this brain-related subtype, especially when there is a hearing loss combined to it in elder patients, it is even more important.
Just remember, guys, there are treatments available for all of these subtypes. When you have the right diagnosis, working with the right professional, have hope. There are things you can do. Dr. Golenhofen, what general advice would you have to those listening, individuals with tinnitus, and then particularly those who have tried a few things on their own? Maybe they've gone to an ENT doctor. Maybe they've tried herbal supplements. Maybe they've just waited. Maybe they've tried some simple sound therapy. Still, they're dealing with this persistent sound. Any advice to them?
First of all, we want to know what disorder is causing the tinnitus. This is the most important step. Never, ever try to do a treatment without being specific about the disorder that is causing the perception. When you have done this, things become so much easier. And this is my message for you. First, try to find the causing disorders behind your tinnitus perception. This is the game changer, because then you can focus on your therapy and you can be assured that most of those disorders are treatable and curable. It's just a matter of time that you go and do the treatment. And at the same time, we need to know only a few centers worldwide are focusing on the diagnose-centered approach of tinnitus management. I'm very glad that you are, Ben, and you help the patient to find some meaning behind all this. And this is the way we should do medicine, and this is the way we should do tinnitus treatments. And when we do make things transparent, you make them manageable. Things become so much easier.
And from the data, from the numbers for patients, I'm seeing that when our team focuses on this diagnosis-centered approach, the overall outcomes are better. And that shows us tinnitus is not a one-size-fits-all thing. I wanted to ask you, where can patients who are listening here, where can they follow some of your work? I'll also mention that we have recorded 2 previous podcasts that go a bit more in depth into the root cause subtype. So you can search Dr. Michael Golenhofen on YouTube, tinnitus, and you should be able to listen to those previous podcasts. But any other resources or places where patients can learn more about your contribution?
Yeah, that's actually a very new thing that I love to share with you. On one side, I'm available as an ENT physician with my practice, with my website that I designed newly in these days. And any patient from anywhere in the world can approach me and can get further advice from an ENT physician on top of what you already worked with UBAN or with any other center. So as an ENT physician, I'm available. And in a couple of days, we will launch another platform that is here to inform patients, actually in this moment, customers then, because it's only some medical information made available on a platform. And it's actually 4 products that I published there right now. It's a little booklet that informs about the diagnose-centered approach. It is an online course that you can watch and be informed in detail about those subtypes, about the treatment, about resources that you can use. It will be also an app that will be helpful in learning those techniques in detail when you still have questions and want to learn something very specifically. There will be an app that publishes tutorial videos about techniques. And there is one retreat that we do twice a year in Sardinia with 12 patients that are trained in these methods that are used to treat the different subtypes. So this informational platform will be published in a couple of days or weeks. And this is basically where you can find what I have to say.
If you want to take the information from today's podcast and put it into action, reach out to our team at Treble Health. We offer a free call with a specialist who can guide you towards a solution towards effective tinnitus treatment. Click the link right here on the screen to book a free call today, and you'll get connected with a specialist from my team at Treble Health. Thanks for watching this podcast, and if you need help, you know we're here for you. Be well.